Hello everyone, welcome back to Toxicology, part of Southern Union EMS's virtual classroom. Today, with this lecture, we're going to continue talking about the the assessment, and the management of abuse and overdose with specific substances. In this particular one, we're going to talk about hallucinogens, sedative hypnotics, and narcotic opiate and opioids. So the first class we're going to talk about are hallucinogens. Hallucinogens cause a distortion of the patient's sense of perception. That's the point in them taking it. It takes them out of the realistic realm. A hallucinogen is a substance that can impair judgment, alter the user's perception of reality, and create a realistic sensation of images or sounds that are not actually present. Experiences with hallucinogens are unpredictable and can vary markedly from person to person. The drug experience is affected by the user's previous drug experience, the dose taken, and the social setting. You need to keep this information in your mind when you move the patient into an environment that may have bright lights, loud sirens, and significant bumps of vibrations. Heightened senses, heightened sense of awareness, as far as with the sensory mechanisms are going to be very important, and this could actually cause a patient to have issues. These substances can be classified into two categories. You've got your synthetic and your naturally occurring. Your synthetic, LSD, PCP, and ketamine, where your naturally occurring is going to be mescaline, psilocybin mushrooms, and the seeds of the Jimson weed plant. The first one we're going to talk about with synthetic is going to be LSD, or lysergic acid diethylamide. It's derived from a fungus, and it primarily affects the senses. It has several physiologic effects on the patient. It has the ability to distort reality, change a person's mood, or alter perceptions and reality. It may also result in the user experiencing synthesias, which is a crossing of both senses. So this is where you're going to taste red and hear blue. Because of the potency of LSD, even small doses may create a significant experience for the first time, and higher doses may lead to more intense effects. Again, from the physiologic perspective, LSD is mostly sympathomimetic. So, of course, you will see issues with tachycardia, palpitations, mydriasis, and sweating. Say the person has a bad trip. This is when the user experiences frightening nightmares, anxiety attacks, and the issue here is that LSD has to wear off. There's really nothing that can fix the bad trip or fix the issues other than allowing it to wear off. Phencyclidine, PCP, typically smoked or snorted. It is a dissociative anesthetic with hallucinogenic properties, also called angel dust or rocket fuel. So interesting enough, it was developed in the 1950s as a IV anesthetic, but it's no longer used for any medical purpose in the United States. PCP works at the NMDA receptors. As a dissociative drug, PCP has the ability to distort sight and sound and make the user feel separated from his or her own body. Typically smoked, snorted, although it can be injected. PCP can cause some of the most violent and difficult behavior you will encounter in the field. Patient may rapidly change moods and attack without warning. For that reason, the safety of the EMS team is a continuous concern when responding to calls involving PCP users. These people get superpowers. Essentially, they get to where they will just absolutely be a danger to themselves and especially to others. So in the cases like in that video, you may have to consider IM sedatives for this patient, and you may need high dosages, but this patient's getting to the point to where he is in excited delirium, and it's very dangerous for him. Um, Obviously, you want to get it to where this person could essentially take your life if he got his hands on you, so you really need to be very careful with these types of patients. Ketamine, when used illicitly. Ketamine on the streets, also known as vitamin K or Special K. This is another dissociative anesthetic. It's relatively short-acting, has lots of clinical uses, veterinary medical fields, but when it's used illicitly, it's often added to other illicit drugs to provide a more intense experience. Like PCP, ketamine works at the NMDA receptors. It also binds to the mu opioid receptors, giving it the analgesic property. So again, ketamine is a good drug clinically when used in the right situation. With ketamine, violent outbreaks are much less likely than with PCP, but the principles of management are the same for patients who have either drug. Keep a close eye on the patient because violent behavior can occur suddenly. And again, any patient that is violent that you have to chemically restrain may have to be done so with benzos. Peyote and mescaline. So these are going to fall under the natural hallucinogenics. Native tribes in the southwestern United States and Mexico have been using these for years, thousands of years. These are Schedule I substances with a high potential for abuse and no currently accepted medical use in the United States. The exact mechanism of action for mescaline hasn't been determined. The dried flower buttons may be ingested or soaked in water to produce a liquid infused with mescaline. Produces a psychedelic experience, which begins with feelings of increased sensitivity to sensory stimulation, flashes of color, distortion of time and space, out-of-body experiences, physical effects, dilated pupils, increased pulse rate, mild hypertension, and increased body temperature, sympathetic effects. So, assessment and management pre-hospital care is going to be supportive for these patients. Psilocybin mushrooms. So these are shrooms that contain hallucinogenic substances, psilocybin and psilocin. Typical dose is estimated to be 4 to 10 milligrams, which is going to be 2 to 4 mushrooms. Often masked with other liquids or foods because of the bitter taste, made into teas and things like that. Onset of symptoms is usually around 30 minutes. Muscle weakness, drowsiness, nausea, vomiting, mydriasis, mild tachycardia, mild hypertension. Serious medical effects are typically pretty low. Seizures and hyperthermia have been reported. Your treatment for these patients, again, is going to be supportive. Sedatives and hypnotics. CNS depressants, often used for anxiety reduction, sleep aid, very high potential for abuse. A sedative is used to reduce anxiety and calm agitation, whereas a hypnotic is used as sleeping aid. You got 4 basic configurations of barbiturates. long-acting, intermediate-acting, short-acting, and ultra-short-acting. Barbiturates, they're a class of medications that act on a CNS depressant. They are used as anxiolytics, anticonvulsants, and hypnotics, clinically similar to alcohol in terms of dependence and withdrawal symptoms. Often patients who attempt suicide with these combine with alcohol. Barbiturates potentiate the gamma-aminobutyric acid, or the GABA, at specific receptors to inhibit cellular excitation. Common barbiturate is going to be phenobarbital. Airway is the first priority. Monitor oxygenation and ventilation. Also look out for signs of withdrawal. If shock develops, crystalloids may be needed. The patient should withhold from having an abrupt cessation of these drugs, but withdrawal symptoms occur within 24 hours of the last dose. Rapid transport is indicated with these patients. For long-acting barbiturates, contact med control to administer a dose of sodium bicarbonate to help alkalize the urine. Benzodiazepines, these are members of the sedative hypnotic family and also have a very big role in healthcare. You've got different potencies of drugs, but benzodiazepines, they stimulate the GABA acid pathways as well. These result in sedation, reduced anxiety. The IV route is a preferred route in the pre-hospital setting. Your pre-hospital benzos, these are going to include diazepam, lorazepam, midazolam. A single entity overdose has a low morbidity rate. However, if a patient is overdosed with benzos, there is an antidote, which is flumazenil, also known as Ramazicon, but it has been a little controversial as far as the pre-hospital reversal of benzodiazepine overdose, simply for the fact that you could invoke withdrawals, which is actually going to be worse on the patient than the actual overdose itself, as long as they're maintaining their airway. So you certainly should follow med control in those situations there. All right, narcotics, opiates, and opioids. A narcotic is a drug that acts as CNS depressants. They produce insensibility or stupor. Opiates are natural drugs derived from opium, and opioids are non-opium derived synthetics. In recent years, potent drugs such as carfentanil and desomorphine have increased in the use on the streets, and these are very dangerous, highly potent drugs. Pre-hospital providers have seen a significant increase in the number of opioid overdoses since 2000. Prescription opioids and heroin are the primary drugs associated with these overdose deaths. New FDA guidelines for opioid use include address a lack of non-opioid alternatives for pain management, address guidelines for writing opioid prescriptions, and create a better evidence base to guide the use of opioid medication. To reduce overdoses, the FDA has approved an auto-injector device that delivers an IM or sub-Q injection of Narcan, and approved intranasal devices to administer Narcan. Always ask whether naloxone has been administered by family members, bystanders, or other responders. And rapid recognition of opioid overdose followed by appropriate treatment is critical. Always want to manage airway, watch for airway. So they bind with receptor sites in the brain and tissues. Three main opioid receptor sites, the delta, the kappa, and the mu or mu. These receptor sites can produce analgesia and euphoric sensations. Opioids can be pretty much taken in any types of ways. The effects are lessened when taken orally due to first pass metabolism, but the doses taken through the IV or the IM route do not go through that first pass mechanism, and so they will go directly to the CNS, which causes more potentiated effects. Assessment for these patients, the big thing that we're concerned again is going to be respiratory depression. If the patient is not experiencing severe respiratory depression and they're still managing their airway, it's probably in your best interest to not administer Narcan, simply for the fact that, again, you don't want to induce withdrawal symptoms. You want to just manage the patient, and so if you keep from inducing withdrawal symptoms and the patient's able to manage their airway, don't give the Narcan. If the patient needs Narcan, though, if they are experiencing hemodynamic compromise, respiratory depression, then administer it. If they don't respond to Narcan, he or she may have taken a potent synthetic drug, or he or she may have taken multiple drugs. So Narcan really only works at those opioid receptors, and so if there's another type of drug on board, then Narcan's not going to work. All right, so here's your treatment algorithm here. Naloxone as soon as it is possible, 2 milligrams intranasal or 0.4 milligrams intramuscular. If they don't respond and they're not breathing, then of course CPR and airway management. If they do respond, stimulate and reassess. So this concludes part 3 of toxicology. Thank you for listening. My email is nickray@suscc.edu.